Welcome to the First Principles of Medicine podcast. In this version of the 1pm podcast, we've decided to cut down a lot of the banter and tangential talking and leave it with just the key facts about the management of heart failure. Take it away, Jason.
Okay, hi everyone. Welcome to the First Principles of Medicine podcast. My name's Jason and today we'll be discussing management of heart failure. So, we'll first go through how it's classified. What are the two main classifications of heart failure?
Preserved ejection and reduced ejection.
Yeah. So, what does preserved ejection fraction even mean?
That the ejection fraction is more than 50% in preserved and reduced is less than 50%.
Yeah, so usually the preserved ejection fraction means that the ejection fraction is greater than 50% and the reduced one is less than 40%, okay?
Oh, 40, not 50.
Yeah, 40.
Oh, okay.
Okay. To begin with, in a clinical environment, usually heart failure is broken down into two different types based on the ejection fraction.
Okay.
And can someone explain to me how is the ejection fraction calculated?
The end systolic volume. It's the end diastolic volume minus end systolic volume.
Yeah.
Right?
Or like a proportion of that, yeah. So what actually is the end diastolic volume?
So the end diastolic volume is the amount of blood in the heart or in the left ventricle at the end of diastole, at the end of filling.
Yeah, and what's the end systolic volume?
So the end systolic volume is the amount of blood left over in the heart after systole, after contraction.
And does anyone know what the usual or what the normal person's ejection fraction is, percentage-wise?
Normal is 50 to 75.
Yeah. So first, heart failure with reduced ejection fraction is classified by two things. So symptoms and signs and a left ventricular ejection fraction less than 40% are the two main criteria needed to fulfill heart failure with reduced ejection fraction.
Okay.
And now for heart failure with preserved ejection fraction, does anyone know what the criteria are? There are like three basic ones.
Would it be the preserved ejection fraction but symptomatic?
Yep. So signs and symptoms is one. The left ventricular ejection fraction has to be greater than what?
50%.
50 to 60?
Oh, it has to be greater than 50%.
50%.
Okay. And there's another criteria which is different to heart failure with the reduced ejection fraction. Okay. Does anyone know?
Are we talking about like hypertrophy or something like that?
So one of the criteria is structural changes compatible with increased left ventricular filling, like left ventricular hypertrophy or left atrial enlargement. So that's a sign.
Okay.
Or there could be signs of something else. Diastolic dysfunction. Okay. As well, with preserved ejection fraction, you also get elevated levels of natriuretic peptides.
Natriuretic.
Yeah, I think like BNP and stuff.
Yeah.
Because can you imagine, you do an echo on someone, their ejection fraction is normal, they're symptomatic, so how can you confirm they've got heart failure with preserved ejection fraction? You need to look for some other signs.
Right, okay.
So the reason why I've gone through all this rigmarole is that heart failure with reduced ejection fraction is managed a lot differently to heart failure with preserved ejection fraction. Basically, heart failure with preserved ejection fraction only has symptomatic treatment, whereas heart failure with reduced ejection fraction has symptomatic and prognostic medication available.
Yeah.
Okay. But now we're going to get to the fun part. This is the main part of the presentation today. So for management of heart failure with reduced ejection fraction, we've got the medical and non-medical sides of management. So we're going to start off with the medical management first. So basically there are 5 main prognostic medications. Does anyone want to spitball what one of them could be?
ACE inhibitors?
Yeah, that's one. JT, what about you?
ARBs, do they count as the same class as ACE inhibitors?
Yeah, I'll count them the same. So we've got ACE inhibitors or ARBs.
Beta blockers?
Yeah, beta blockers one.
Diuretics?
So diuretics is technically not a prognostic medication. It's the primary symptomatic medication. Okay?
MRAs?
Yeah, what do you mean by MRA?
Mineral corticoid antagonist?
Yep, you're right. So you've got
spironolactone, is that one of them?
Yeah, that's a name for it. So we've got ACE inhibitors, beta blockers, and mineralocorticoid receptor antagonists.
Right, cool.
Okay, we've got 2 more.
2 more.
SGLT2 inhibitors?
Yeah, that's
really?
And there's one last one.
Give me a clue.
It's related to the ACE It's related to the RAS system, and it's kind of a newish drug.
Give us another clue.
It's probably it uses.
What does it rhyme with?
It uses okay. It's actually like a combination of two different drugs. One part of the drug is an ARB, and the other one is a totally different mechanism.
Is this? We've seen this before. We know.
You may if
I don't think I've seen
in the hospital. It's quite like you
What's
do
the
see it.
suffix?
Well, you probably never heard of it, but it's called an angiotensin receptor nephrolysin inhibitor.
That's definitely something I've not heard of
Yeah,
before.
no.
It's
Nephronizing.
under the name Entresto.
Nah.
Surely you never heard of Entresto.
Oh, I'm sorry. Yeah.
Hey man, we haven't been on the card.
Yeah.
yet.
Anyway,
Alright, buddy.
so this is like a new generation drug.
These are
relatively.
5 classes of drugs, to recap?
Yeah.
Okay, so,
Okay.
So these
ACE,
are-
ARB, and then that special ARB, and then beta blocker, the SGLT2 thing,
Inhibitors.
and
MRAs?
MRAs.
Yeah.
Okay.
Okay, now that we've gone through those 5 medications, it's probably good to actually understand the first principles.
Sounds
okay,
good.
so let's go through the first one, ACE inhibitor. Yeah, so ACE inhibitors end in prils, and they inhibit angiotensin converting enzyme, which is important in converting angiotensin 1 to angiotensin 2.
Mm-hmm.
And why would that be important for heart failure management?
So the
Renin.
renin-angiotensin-aldosterone system is involved in basically retaining salt, retaining water, which will increase blood volume, increase blood pressure, which is not good for a failing heart.
Basically, from my understanding, ACE inhibitors help to reduce the preload and reduce the afterload, which makes it easy for the heart to function. Okay? Now let's go on to beta blockers. What type of beta blockers first do you want to use?
Selectivity.
Oh,
Yes.
the heart
Cardioselective.
specific.
Make sure you say
Yeah,
cardioselective.
cardioselective, yeah.
Okay?
Yeah.
Okay? And it's important to specify that it's cardioselective. For medical school, it's just easy just remember one example.
Okay.
So one example of that is bisoprolol.
Yeah.
It ends in olo.
Yeah.
Yep, so that's cardioselective beta blocker.
How does a beta blocker work?
Reduce heart rate and contractility
Yep. So why do you want to reduce heart rate and contractility?
because you don't want the heart to overwork.
Yep.
Reduce
As
the
in-
work of the
yeah,
heart.
reduce the work
Yeah.
of the heart.
Yeah, and the main issue with the heart working a lot, it's failing, right? It's not working well. Okay, so there are a lot of signals to try to kick it up its ass to get it to work a lot. And with those signals, which get it to work harder and harder, that can lead to cardiac remodeling or hypertrophy. Okay, so next one is mineralocorticoid receptor antagonists. What do they do?
I think it's a
Yeah.
sodium-potassium
Yeah.
ATPase on the basolateral membrane of
Shut the
the
fuck
cells
up.
of the distal convolution.
Yes.
Yeah.
Reduces sodium retention and then fluid retention. So less sodium into the water follows sodium. So
Yes.
less reabsorption means more excretion. And then does that downstream affect less afterload or less fluid?
Yeah.
Yeah.
It's a
And then
diuretic, so you get rid of
pretty
more
much it.
water.
So then less afterload, easier for the heart.
Yeah. Next one, SGLT2 inhibitors. How do they work?
Well, from my understanding of diabetes, SGLT2 is a transporter, I think, in the kidneys, and it's an inhibitor with the small I, so it inhibits the glucose reabsorption into the body. So then I guess water also follows the glucose.
And the last one is the angiotensin receptor nephrolysin inhibitor.
Fuck this.
AKA Entresto, because I never remember the other one.
Entresto.
Entresto.
Yeah.
So that's a combination of sacubitril. Somebody, I probably absolutely
is that?
butchered that. That's the nephrolysin thingamajiggy.
Nephrolysin.
How do you spell that?
Dude, I don't fucking.
So
What's its
nephro
mechanism?
is kidney.
But lysing's like
I'm
Split
quite-
the kidney.
I'm quite sure. Let me look it up.
Well, yeah, so what is its
Yeah, so
mechanism?
yeah.
The
I'm
water's
sure it
coming
doesn't
up.
do
The
that.
water's coming up or something.
diuretic. It's diuretic. Diuretic.
Basically, wait. So apparently they work by blocking the action of nephrolysin, thus preventing
No.
the breakdown
Oh.
of natriuretic peptides.
Okay.
Okay? But anyway, that in combination with an ARB is Entresto.
So Entresto.
Yeah.
Would someone be on an ARB separate?
I'll go through how
Okay,
you
okay.
actually, like the formula to... So, now that we know the 5 drugs,
Yeah.
we're going to go through what I call like the medication selection algorithm. Okay?
Yeah.
So let's say a person comes in with heart failure,
Yeah.
which is a bit decompensated, they're a bit fluid overloaded.
Yeah.
Okay. Things
This
like
is
that.
reduced, right?
Yeah.
Reduced ejection? REF? Or
Yeah, we're with REF. So I've been talking about REF this whole time because once again, PEF is only managed for symptomatic.
Yeah.
So we're going to go through now the medication selection algorithm. Okay?
Yeah.
So patient comes in, they're short of breath, they're fluid overloaded. Do you think they're in heart failure? Okay?
Yeah. Okay.
The way that it usually goes about is that you're giving them diuretics, you're giving them the ACE inhibitors and beta blockers. You then reassess, and then you have to kind of decide whether they need other prognostic medication. And that's usually based on two things.
Mm-hmm.
So if they're still symptomatic and their left ventricular
Yeah.
ejection fraction is less than 35%,
35%.
then you go into adding on the other therapy. And what are the other three drugs?
JT. MRA.
Dapagliflozin.
Yeah.
SGLT2 inhibitor. The special diuretic, the MRA.
Yeah.
The Spiro.
Yeah, and last one you mentioned was Entresto. So basically what happens with Entresto is that kind of replaces the ACE inhibitor or the ARB,
Mm-hmm.
but because it's a relatively new drug, my understanding is that you have to first prove that the management has kind of failed with ACE inhibitor.
Right.
So then you can be qualified to give Entresto. Okay? So whilst I gave the therapeutic algorithm, in reality, sometimes you have patients come in with like left ejection fraction less than like 15%,
Right.
10 to 15%. And it's not like you just start them on the ACE inhibitor and beta blocker and then you wait and see. Usually you kind of just chuck all 5 or 4
Right.
at the same time, and just kind of monitor and make sure they're stable. So it usually involves a bit of playing around with the doses, playing around, like seeing whether they have any side effects,
Yeah.
maybe starting one at a time or slowly adding all of them.
Just with the drugs, are
Yeah,
there any
yeah.
risks to giving any of the drugs?
Of course.
Of course, but
As
you know
in
what?
terms of if they've got decompensated
Mm.
heart failure.
Beta blocker.
Yeah, beta blockers.
Yeah, so beta blockers, you want to make sure they're stable
Mm.
before giving it to them.
Mm.
Aldosterone antagonists, whatever. You have to
Spiro.
be careful of high potassium, SGLT2 inhibitors. If they're diabetic, you can get euglycemic ketoacidosis. But you know what? Those are all things everyone can look up. But yeah,
I
those.
guess probably pretty important, but sure. Yeah.
Yeah, pretty important. But do we have like freaking 2 hours to go through this?
Okay, yeah. Because yeah, go.
No.
I'm just preparing you guys so that when the consultant asks you what medication, what are the 5 prognostic medication? They love saying prognostic, okay? You can tell
I remember I was actually asked last year, beta blockers, yes, but if someone's like just come in, still fluid overloaded, if you give them beta blockers, you make it worse. So you've got to wait until they're stable first.
Yeah. So I should have
that's
emphasized that more. But
that's probably
usually when you
important.
get
Yeah.
yeah. So yeah, what 80 and 7 is right. Yeah, the beta blockers, once they're stable, is very important.
But yeah, makes sense.
Okay, and then non-pharmacological. Okay, we'll just go through that briefly. There are 3 main things.
Let's
Okay.
go.
Should we guess or not
Yeah,
guess?
can you guys guess?
Go
Come
for
on.
it.
Fluid restriction.
Yes, and what are you usually? What's the standard kind of fluid restriction?
I've seen 1.5.
Yeah, 1.5 liter. Okay,
Mm.
and what's the rationale behind that?
To reduce their fluid intake.
Yeah, simple. Okay, next one.
Simple.
Salt restriction.
Yeah, and what are you aiming for usually?
2 grams.
Yeah,
3
for-
grams.
I think less than 3 usually.
Oh,
And
okay.
what's the rationale once again for reducing the salt?
Reducing fluid retention.
Yeah, because as you said, where salt is, that's where water kind of goes. Yeah, and last one. This one's the one you can't really guess.
This one.
It's called cardiopulmonary rehab. To end this
Okay.
episode, could someone recap to me the 5 prognostic medications you use for heart failure with reduced ejection fraction?
Okay.
ACE inhibitors or ARBs, mineralocorticoid receptor antagonists, SGLT2 inhibitors such as empagliflozin, Entresto.
Yeah.
Beta blockers. Sorry,
Yeah.
and I probably should have said that differently. ACE inhibitors, beta blockers, because they're.
You know, I would actually be so disappointed if you guys didn't remember these 5 medications.
I remember.
But anyway, thank you all for listening. Hope you have all retained some first principles and at least remember 5 medications for heart failure.
Thanks for listening, guys. If you liked this episode, feel free to check out the rest of our episodes available on Spotify. Leave us a review and a like. And don't forget to check out all the other resources, including Anki decks of each of the conditions we talk about on the podcast, available on the 1PM Notion website. Thank you.